Well, I'd like to begin by acknowledging the traditional owners of the land on which we meet, the Gadigal people of the Aurora Nation, and extend and pay my respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Today, we're very honored to have Professor Dr. Randi Hagerman to join us and give us a talk about the premutation. She's been working on the premutation and Fragile X for some 40 years, and she's at the Mind Institute, a part of the UC Davis Medical School in California there, and she holds the endowed chair in Fragile X research. And she runs the clinical trials program, and she's the medical director at the Mind Institute. And she's published many, many articles, over 400 by my count, related to Fragile X and related disorders. Now, I'd like to give just a short background. Randi was here in 1985, and I came and we had a small safari that went from Cairns up to Cooktown and back in 2 vehicles. And this picture shows Randi with her 2 daughters, Karen and Hillary, and Paul's in the background there. And also Jillian Turner's there with Michael Partington. We went up in these 2 vehicles on a trip up north. Here's a couple more pictures of Randi and her daughter there with Jillian Turner. And then we came back to Dunk Island, where we had a conference. It was the 2nd international conference on Fragile X. And I took these pictures, so I'm not in it, but you can see Randi and Paul in the middle of the picture, and Grant Sutherland in the front, and Jillian Turner there, and many other people that worked on Fragile X at the time. So we've had these meetings on Fragile X every couple of years for a long time now. So I'm going to turn it over to Andrea, who will give an introduction to the New Zealand portion.
Thanks, Ted. Sorry, I'm just unmuting myself. Tēnā koutou katoa, and a warm welcome to everyone joining the webinar today. In Aotearoa, New Zealand, I acknowledge the tangata whenua, the first people of Aotearoa. The Treaty of Waitangi between Māori and Pākehā is our founding partnership document. My name is Andrea Lee, and I work as the Executive Director of Fragile X New Zealand. So I'm also the mother of a 17-year-old young man with Fragile X and a premutation carrier myself. So we're thrilled to again be partnering with the Australian Fragile X community and bring you this webinar today. It's my very great pleasure to welcome Randi Hagerman.
Thank you so very much. I just want to show people a picture of the Mind Institute and the entrance hall, which gives families a vision of hope. Here's some team members. I have a picture of my assistant, Julie Morcillo, who schedules me. And of course, Robbie Miller here, who works 1 day a week to head up our international training program for neurodevelopmental disorders. So again, I'm going to talk about premutation disorders and conditions. You know, I've received funding from NICHD, Israeli, Zenurba, Anabec Life Sciences, and Neuronext. I've done some consulting a few years back with Zenurba about Fragile X clinical trials. And then I'm starting my talk here with the year 2000, because this was a very seminal year, even though we had been working on premutation disorders all during the 1990s. And actually, we first reported early ovarian insufficiency in 1991. And then many other labs also confirmed that. But 2000 was the year that Dr. Flora Tassoni, who was working in Paul's lab. Under Flora's picture here is my husband, Paul Hagerman. At the time, he came to medical school when I first met him and grabbed him up into a marriage. But that's where Flora discovered the elevated messenger RNA in premutation carriers, and that was reported in 2000 in the American Journal of Human Genetics. So 2000 was also the year when the National Fragile X Foundation had their international conference in Los Angeles, and we presented the first 5 cases of individuals who had tremor and ataxia with the premutation And we later named this FactsTasks for Fragile X associated tremor ataxia syndrome. And 2000 was also the year we moved from University of California, University of Colorado, where we had a Fragile X clinic going for about 20 years. And we moved to the Mind Institute because it was an endowed chair that was very attractive, allowing us to really expand our research on Fragile X disorders. And at that time, we had a patient that died of FXTAS, and we actually carried his brain with us, and I'll show you in just a few slides down about what we found in his brain. That was the FXTAS inclusions. So just to get everybody on the same page, it's important to know that there are, of course, 2 different mutations in the FMR1 gene. The full mutation, which is more than 200 repeats, and it's usually methylated, and that's what these little orange dots represent, a methyl group on the backbone of the DNA. And when that occurs, it shuts down the gene, so there's little or no message produced, or messenger RNA produced, and little or no protein, and that causes Fragile X syndrome, as you see here in this little boy. But the pre-mutation is much more common than the full mutation. You know, the full mutation is about 1 in 4,000 to 1 in 5,000, although it varies in different parts of the world. But the pre-mutation can be as frequent as 1 in 130 females and 1 in 250 males, depending on what part of the world you look at. But the pre-mutation, meaning 55 to 200 CGG repeats, is hardly ever methylated, and it produces way too much messenger RNA. And the higher the pre-mutation is, the more message produced. And the more message produced, actually, the lower the level of FMRP. Usually it's normal, but the Fragile X protein, the translation of the protein can get stalled when the CGG repeat is too long. So that's how they can get slightly lowered message. You think that excess messenger RNA would increase the level of the Fragile X protein, but in fact, it stalls the translation of the message to produce the protein. So there's a variety of premutation disorders that we're going to talk about today. One is the primary ovarian insufficiency, or FXPOI, and also FactsTasks, the tremor and ataxia disorder, and also Fragile X neuropsychiatric disorders, which we named FXAND. The Europeans did not like the term disorders. They would rather have the term conditions. So there's also FXPAC, but that usually includes depression, anxiety, ADHD, sometimes autism spectrum disorders, sometimes obsessive compulsive disorder, chronic fatigue, chronic pain, fibromyalgia, and we'll talk a lot more about these problems. So it's important, again, if you see here on this chart, this is the level of messenger RNA, as you can see here, and this is the level of protein. So one of my main collaborators in Australia is Dr. Danuta Losh, and she's an amazing researcher at La Trobe University in Melbourne. And she's the one that's really talked about, you know, an increase in messenger RNA levels, even in the gray zone, which is 45 to 55. And she sees a higher incidence of Parkinson's disease or Parkinsonian symptoms in this gray zone. But the pre-mutation, again, with FactsTasks, FXPOI, FXAND, is associated with this elevated messenger RNA. And as the CGG repeat number increases, the level of message increases up to about 8 times normal. And then, of course, it falls in the full mutation range once methylation sets in, which it does for the majority. But it's important to realize that as the messenger RNA goes up, sometimes, usually about over 120 CGG repeats, there can be a somewhat of a decrement of FMRP levels, and that can lead to some Fragile X syndrome-like features. Even on occasion, the upper end of the premutation sometimes can be methylated, and that's why I have Fragile X syndrome not only occurring in the full mutation range, but sometimes the upper end of the premutation can have a lot of Fragile X-like features, particularly some of the connective tissue features, because of the lowered protein level. So Fragile X disorders, or it's sometimes called Fragile X spectrum disorders, of course, includes Fragile X syndrome, but the Fragile X associated disorders usually refer to premutation problems. So we have FXTAS, FXPOI, FXAND, or FXPAC. And again, in childhood, this can occur because the RNA toxicity can impact childhood development, and it oftentimes can cause ADHD. On occasion, it could cause autism spectrum disorder. And the most common problem is anxiety disorders, very common in premutation carriers, even in childhood. But in adulthood, sometimes more problems with depression, anxiety, obsessive compulsive behavior, chronic fatigue, chronic pain. Insomnia is a big problem in many carriers. And fibromyalgia, meaning pain in the muscles, particularly when the muscles are touched. And that's a problem that can occur in 20% or more of particularly female carriers. It's rare that we see a male carrier with fibromyalgia, but occasionally that has occurred. Now, FactsTasks is really the most severe clinical problem in premutation carriers. And again, this is related to the consequences of the elevated messenger RNA. We'll talk about other effects too. It usually involves tremor and ataxia, neuropathy, cognitive deficits, and is progressive over time. And it's at the most severe end of the spectrum of premutation involvement. Overall, it affects about 40% of males and anywhere from 13 to 16% of females. But these numbers, or the prevalence, can become more frequent with age. So in the 80s, it affects about 75% of males in their 80s, and we haven't followed enough women through time to know what percentage are affected in the 80s. We first described it in 2001 in a neurology paper. We named it FactsTasks in 2003 in an American Journal of Human Genetics paper. And we, in 2004, we reported on the prevalence, at least in California families. Now, FactsTasks in males, here's a couple of males with FactsTasks. This one is in a wheelchair, actually, not only because of FactsTasks, but many individuals with FactsTasks can have car accidents, and he had a car accident where he lost his leg, and it actually killed others in the car. So you have to be very careful and hopefully avoid driving if there's anyone else in the car. It typically starts in the early 60s. Typically it starts with tremor, and a couple years later, ataxia, and then individuals can go from needing a cane to a walker to a wheelchair. And eventually individuals with severe FactsTasks can be bedridden. It also can have psychiatric symptoms like disinhibition, mood lability, sometimes aggressiveness. Sleep apnea is very common, and that tends to progress the white matter disease. So we always recommend a sleep apnea study because we don't want individuals becoming more hypoxic or having lower oxygen levels at night. There's emotional problems that also can come from the loss of functioning. You know, it's really hard not to be able to work or drive and to maintain your cognitive level. We are concerned about the toxicity of some types of surgery, particularly the isoflurane or any of the halogenated general anesthetics, because that can be hard on the brain. And sometimes the tremor and ataxia can develop after having a major surgery. We'll talk more about the treatment recommendations, but we do recommend vitamins and antioxidants and exercise. And we'll talk in just a little bit about medications for tremor or psychiatric symptoms. In females, the risk is lower, up to 16%. It may present as in the males with head tremor first, but we've seen a lot that have developed autoimmune problems even before the onset of FactsTasks, hypothyroidism, fibromyalgia, muscle pain, neuropathy, arthritis, essential pain syndrome, chronic fatigue. These are very common problems. And sometimes psychiatric symptoms can move into FXTAS, and sometimes it can just, in the female, sometimes it can just present with some cognitive changes. Now, oftentimes when females have gone to the doctor, particularly about some psychiatric problems, sometimes the doctors just feel that the women are hypochondriacs or just under stress from raising a child with Fragile X syndrome. And that's true. Raising a child with Fragile X syndrome can cause a lot of stress. But because many doctors did not pay attention to the psychiatric symptoms, that's why we created the term FXAND, so that physicians who may not be that familiar with premutation problems, particularly in women, will pay more attention to the psychiatric symptoms, because it is not good for the brain to persist with psychiatric symptoms. A recent paper we did looking at females versus males in 104 patients with FXTAS, 41 females and 63 males. This is a paper that is undergoing, it's basically been accepted, but we're making just a few changes. And one of the things we noticed is that there's more pain symptoms in women with FXTAS compared to males. It's not only allodynia, that can be pain to the touch or fibromyalgia, but peripheral neuropathic pain, muscle pain, back pain. These were significantly more common in females compared to males, and you see the figure here. We did find that peripheral neuropathy, with or without pain, can correlate with the onset of ataxia across genders. Women also report significantly more anxiety than the males. I don't know whether women just find it easier to talk about psychiatric symptoms than many males do. I think that may be part of the issue. But depression seems to occur equally in about a quarter of the males versus females. Females with FXTAS are significantly more likely to be taking any pain medication compared to males, as well as nerve pain medication like gabapentin. And FXTAS women are far more likely to have thyroid problems, particularly hypothyroidism, which again is usually an autoimmune problem. Now, Daduda Loesch and her team just reported this year that females with FXTAS have much faster progression of their psychiatric symptoms than males do, but males have faster progression of the motor symptoms like tremor and balance problems compared to the females. So there are some important differences between males and females. We also see more white matter disease in the MRI changes in the males compared to the females. Now, how do you diagnose FXTAS? Well, the major clinical criteria are an intention tremor or gait ataxia. That means a balance problem with walking that sometimes can lead to frequent falls. Minor symptoms of Parkinsonism, short-term memory deficits, executive function deficits, and neuropathy, that's pain in the lower extremities, along with muscle tingling in the lower extremities, but oftentimes pain at night. Now, the MRI is what needs to be done to make a diagnosis of FXTAS, and we look for the middle cerebellar peduncles, and these are white matter lesions that I will show you in a minute, but they're seen in about 60% of males with FXTAS, but far less females with FXTAS. So we have definite criteria like a major clinical finding along with the MCP sign, probable FXTAS, and possible FXTAS, because, you know, tremor can be seen more commonly in the general population as you age, along with balance problems, but it's far more severe in those individuals with FXTAS. And then there's a neuropathological diagnostic criteria, which are FXTAS inclusions, which I'll show you in a moment. So let me just see if I can show this video. So here's a woman. I've showed this video for many years. This is a woman, a very smart woman with the premutation. She has now passed away, but she had a gifted IQ, had a PhD, was a nun for many years. And as you can see, she has this intention tremor. She does not have a resting tremor, but some individuals with FXTAS can have a resting tremor. So as you can see, the tremor here interferes with her handwriting and her drawing of drawing between the lines in a circular structure, and that's how we measure it. It can interfere with pouring liquids or with eating because food can fall off the fork. And we did not publish FXTAS in females until 2004 in American Journal of Human Genetics. Here shows some very significant brain atrophy. This is the worst brain atrophy I've ever seen, so I'll show you some less severe ones. This is the white matter disease in the middle cerebellar peduncles. This is going from the pons to the cerebellum. And you can see on FLAIR MRI imaging that it looks like two headlights looking out at you. And here's a FXTAS inclusion that's ubiquitin positive. It's in this neuron. This is the nucleus, and the inclusion stains with ubiquitin. This is the nucleolus, but it also can occur in glial cells besides neurons. And here's a picture of the amygdala, and these inclusions are throughout the amygdala. And as you know, the amygdala is a major emotional processing area of the brain. Here's also a FXTAS mouse, and the inclusions can also occur in the mice with the premutation. So these internuclear inclusions of FXTAS don't just occur in the brain, but they can occur all over the body in numerous peripheral tissues. They can occur in the anterior and posterior pituitary, in the pancreas, adrenal gland, thyroid gland, kidney, heart, dorsal root ganglia of the spinal cord, parasympathetic ganglia. They can occur in the epicardial ganglia for the heart. And these places for the inclusions go along with some of the symptoms that can occur in individuals with FXTAS. For instance, arrhythmias are not uncommon in individuals with FXTAS. And we published a recent paper about cardiovascular problems like AFib or paroxysmal atrial tachycardia and other types of arrhythmias. Can be related to the inclusions that occur in the nerves that control the rhythm in the heart. They also can occur in the testicles, in the Leydig cells, which are the cells that make testosterone. So many individuals with FXTAS are deficient in testosterone, and they oftentimes can present with erectile dysfunction. These inclusions occur in the myenteric ganglia of the stomach and the intestines, and oftentimes constipation is a real problem because the gut doesn't work as well with FXTAS, and even some individuals can have swallowing problems, and the inclusions can interfere with the peristalsis in the esophagus going to the stomach. So it's important to remember that these inclusions can occur in different places, and that leads to some of the global symptoms that we see in FXTAS. So not only is there RNA toxicity, why does the RNA cause problems? Well, it can sequester very important proteins that are critical for neuronal function and take them out of commission so the neuron doesn't do as well. Peter Todd and others have talked about RAND translation. That's repeat associated non-AUG translation, meaning that the translation of the message into the protein actually translates some of the CGG repeats so that the Fragile X protein has what we call a polyglycine or a poly-G tail, and this can be toxic to the neurons. So this could be an important aspect of toxicity. There's mitochondrial dysfunction, which we think is very important, and Cecilia Giolivi and Ellie Napoli from UC Davis have written a lot about the mitochondrial dysfunction. But it's also important to remember that there can be environmental problems. I mentioned about problems with anesthesia. But alcoholism is one of the main problems. I see individuals who are alcoholics and drink way too much wine, particularly at dinner. You know, a bottle of wine is too much at dinner, and that can progress white matter disease. Many individuals with FXTAS, because of pain symptoms, get addicted to opioids, and we've seen that dramatically progress FXTAS. Chemotherapy can do the same. Toxins in the environment. We think pesticides, insecticides, varathane and other inhalants can be bad. Smoking can be bad. If you're a boxer and you get chronic traumatic encephalopathy, that can also be problematic. Or if you have a stroke, that can be problematic. If you have ongoing seizures, that's not too common in premutation carriers, but that could cause more difficulties with the brain. We're looking into migraine headaches, which are very common in carriers, because that can be a little stressful for the brain. It's also important to know that there can be excess iron deposition in the brain, and that can cause its own toxicity. That's why we don't like iron be given to carriers unless they're significantly anemic. And this is just some of the stuff that we've already talked about, the developmental problems like ADHD or ASD. Occasionally we see cognitive deficits, but most of the time, if we see that, sometimes there can be a second genetic hit. And we're writing a paper about that now, about second genetic hits in premutation carriers. So if a carrier has intellectual disability or severe autism, then it's good to do whole genome sequencing to look and see if there's an additional problem besides the premutation, because the premutation is pretty common in the general population. The endocrine dysfunction I mentioned, and we'll talk more about that, hypothyroidism. Immune dysregulation, there can be a variety of other types of immune problems. We've seen about 2% of women with the pre-develop lupus, the same with multiple sclerosis. I just had a gentleman a couple of months ago who had Wegener's granulomatosis. So sometimes rare autoimmune problems can also occur. Why do they occur in premutation carriers? Well, I think because the immune system gets dysregulated, and we've looked at that in an animal and cellular model. And when your immune system doesn't work very well, then that opens you up for autoimmune difficulties. Neurological problems before FXTAS, you know, as we talked about, neuropathy, chronic pain, fatigue, migraine, sleep apnea, restless leg syndrome occurs more commonly in carriers compared to controls, memory problems, foggy thinking. I can't tell you how many women have told me they have foggy thinking. We also see a lot with hypertension, more than the general population, and erectile dysfunction. And then we'll talk a bit more about FXTAS as we go along. But it's important to think about these background genetic problems and molecular problems combined with environmental toxicity, which can progress the disease. This is the gentleman whose brain I brought with me in 2000, and Claudia Greco, the neuropathologist, I remember the day she called me up, and this was in 2001, and she said, "Oh my God, in the brains, I see these inclusions and I've never seen them before." And this is the FXTAS inclusion in a neuron and in glial cells. Here it's ubiquitin positive. This is the first gentleman we diagnosed with FXTAS when we came to California. And my husband, Paul Hagerman, has really done a lot of work with the inclusions. And he's found some, you know, he calls it a molecular pinata, breaks open the inclusions. And this is a mass spec study he did with the inclusions. And there's a lot of this SUMO 1 and 2 and P62 and sequestium, much more than we see in controls. And he really feels, this is a picture of my husband now, and he really feels that the proteasomes, which are kind of the garbage cans in the cell, whenever there's proteins that get tagged for destruction or misfolded and need to be degraded, they get dumped into the proteasome. And finding all these proteins linked with SUMO 1 and 2 and P62 tells him that the proteasome is blocked, kind of like a clogged toilet, and these overflow and then lead to the inclusion formation. He's also done a lot of work on FMRP. Ted has too. This is FMRP with FRET testing. And as you can see, here's normal patients and their FMRP level. Here's gray zone, slightly lowered. Here's the premutation. And as you can see, there's a lot that have high levels of protein and several that have low levels of protein. And again, this is related to the CGG repeat number and whether the translation is stalled. And mosaic individuals have higher levels of protein than those with the full mutation that's fully methylated, but usually their cells are a mixture of premutation and full mutation or methylation mosaic, some with the full mutation that's unmethylated and some that's methylated. And this just shows that, wow, if you get about 60 to 70% of the normal FMRP level, that's enough to maintain a fairly good verbal IQ here. And if you have a higher level, it may not increase the level of IQ. So these are just more pictures of the brain showing what the white matter disease, usually the ventricles are dilated. This one has a little asymmetry. Here's the middle cerebellar peduncle sign and some periventricular white matter disease. This shows how severe the atrophy can be. Here's the middle cerebellar peduncle sign. Sometimes it can be quite extensive, going down into the dentate and in other regions in the cerebellum. But again, most of the time it looks like two headlights looking out at you. But there's other things we look at in the brain too. This is the splenium. This here is the corpus callosum, which is the white matter tracts that connect one side of the brain to the other. And the genu area is the front part and the splenium is the back part. And the splenium seems to be affected more frequently, particularly in women with FXTAS. This one has a little bit of white matter disease in the pons right here. And then the insula, it's kind of like on the inside of the temporal lobe. This is the insula bilaterally, and that can have white matter disease too. So these are other things that we see. The white matter disease can be associated with cognitive and motor deficits. Hawking from La Trobe University has shown that in his paper from 2019. Here's digit span going down. This is on cognitive testing like the Wechsler scale. As you have more white matter disease, you have lowered abilities there. The UPDRS is a Parkinsonian motor kind of standardized evaluation, and it can correlate, the score on the UPDRS can correlate with the degree of white matter disease and also the degree of tremor. But IQ similarities, symbol digit, as a neural psych test, and digit span can correlate with total white matter disease. So we see with more white matter disease, we see more motor problems and also more cognitive deficits. So we have looked cross-sectionally at many carriers compared to controls. I think this study is a few hundred carriers compared to controls. And this just shows the green are normal controls, and the turquoise here are premutation carriers without FXTAS, and the purple here are premutation carriers with FXTAS. And as you can see, there are some changes just in brainstem volume, and the next one is on cerebellar volume. And the age of divergence, it happens in childhood. Like this begins to differentiate between the two populations in childhood, but there's subtle differences there. And here is above age 50, then individuals with FXTAS really start to separate from premutation carriers without FXTAS, which look closer to the normal controls here in the 50s to the 80s. So these are brainstem volumetric changes, but also we see that in cerebellar volumetric changes, and the cerebellum definitely becomes smaller in individuals with FXTAS. So this is all published by Junyi Wang, and here she is. She's an amazing researcher who has published many papers. And this also looks at the log of white matter hyperintensities that we see on FLAIR imaging. And this just shows normal controls, FXTAS stage 1, where you're not even sure there's a tremor, but stage 2, there is a noticeable tremor, but it doesn't interfere very much with activities of daily living. But when it starts to interfere with handwriting and eating, the level of white matter disease goes up. And stage 4 and 5 is when they're using a cane or a walker. And so that's the higher stages of FXTAS, and the white matter disease seems to stay relatively stable at that age. Or that degree of involvement. She's also reported in the fact that some carriers can have hypergyrification. That means increased folding in their brains, and on occasion hypogyrification. And she's also reported, well, actually it hasn't been accepted yet, but the eye of the tiger sign in individuals with FXTAS. And I don't know if you can see this, but if you look at this brain, it looks like this is an eye with the pupil here, and this has to do with the degree of iron deposition in the brain. And this is in the globus pallidus, I believe, but it almost looks like a tiger looking at you. That's not in everybody with FXTAS, but it seems to correlate with more significant involvement. We also have a brain bank that my husband started, and Veronica Martinez Cerdeno, seen in the middle here, is in charge of the brain bank now. And we have 40 brains from patients with FXTAS. 7 were diagnosed with Parkinson's disease or Parkinsonism, and all 7 had dopaminergic neuronal cell loss in the substantia nigra. This is a paper that just came out last year by Maria Jimena Salcido Arellano here. She's a Colombian physician, and she found that in 2 of these 7 brains with a diagnosis, a clinical diagnosis of Parkinson's disease, they also met the neuropathological diagnosis of Parkinson's disease, which is Lewy bodies. And here's a Lewy body, and here's a Lewy body in the neuron. This is stained with dopamine, and I'm sorry, alpha-synuclein, and this is stained with dopamine. So these Lewy bodies do look different from the FXTAS inclusions, but these Lewy bodies can occur in up in 10% of patients with FXTAS, and actually we saw them in 4 brains out of 40 that were looked at in detail, but only 2 of these 4 had the clinical Parkinsonian features or Parkinson's disease clinical symptoms. Some of you may recognize Bella here, or Yingatrana, and she has worked on our FXTAS project for many years, and now she is working in the laboratory trying to figure out some of the molecular aspects or subtyping different groups of FXTAS patients. As I mentioned, iron can be deposited within the brain of those with FXTAS, particularly in the putamen. I don't know if you can see this, but this is a bluish iron stain. Here's a blow up of it compared to control brain. So there's more iron in the FXTAS brain. It's that iron can get deposited, but it doesn't get released into the blood. It just kind of stays in the brain. It activates the microglia, which are kind of some inflammatory cells in the central nervous system, and that can cause more problems with inflammation, and that may be some of the pathological changes that are related to inflammation in the brains of those with FXTAS. So we're trying to learn more about this. Andrea Schneider reported about 53 females with FXTAS versus 55 controls. She saw onset kind of in the middle 60s. The middle cerebellar peduncle sign was only seen in less than 10% or 9.1%, wasn't seen in the controls. The splenium sign, however, was quite common, way more than controls, and the white matter disease in the pons was relatively common, and some of the women had diffuse white matter disease. So she also found in her study, the earlier the CGG or the higher the CGG repeat number, the earlier the onset of FXTAS. And that was also seen in males by Leahy and also by Flora Tassoni in the past. So we see the same thing in women. Here's a picture of the structural MRI findings. These are in the premutation females versus the controls. So the MCP sign is far less common. Changes in the pons. Splenium sign is the most frequent sign, along with general cortical atrophy. But of course, some of the controls get that with aging too. So again, this is the splenium sign, white matter disease, and often it can look kind of almost cystic-like in the back part of the corpus callosum. So again, this is the relationship between CGG repeat and age of onset of tremor, and the same was true for ataxia. Now I want to switch gears a little bit and talk about FXAND, and depression and anxiety can worsen with age in women with the premutation. So this is Jane Roberts' paper from Biological Psychiatry, where she looked at the psychiatric symptoms on the SCID, which is a standardized psychiatric interview. So it's the best type, or it's the best way to diagnose psychiatric problems. And these two time points are separated by about 3 years. These individuals are in middle adulthood. And as you can see, major depression disorder goes up, mood disorders up, bipolar disorder can occur occasionally, but anxiety disorders gets up to 34% by time 2, and any mood or anxiety disorder starts out at about 59%, but goes up to 66%. So after you lose clinical or have more, let me make sure you guys got that slide change, have more neurological problems, then more psychiatric problems can start in association with FXTAS, because it's really anxiety provoking to have a tremor and to drop things and to feel very unstable physically. So it's important also to know that anxiety can shrink the hippocampus. That's true of depression also. And we also see it in individuals with or without FXTAS and the premutation. The circles are those with FXTAS and the triangles are those without FXTAS. So as the anxiety scale goes up, so the size of the right hippocampus goes down. So it's really important to treat the psychiatric problems with selective serotonin reuptake inhibitors, which are called SSRIs or SNRIs, like venlafaxine, which is also a brand name of Effexor, or Cymbalta, or duloxetine, the generic name. Now, many people will say, well, gosh, you know, a lot of people have anxiety or depression. But the point is that this is much more common in individuals with the premutation. Now, the Marshfield study is a study that Marsha Malik has done. And this is a healthcare provider company where they were able to test individuals to see who had the premutation and who did not. And that it was all double-blinded, so they did not tell the healthcare provider nor the patient that they had the premutation. So this is completely blinded, and what we see here is that there's a significant increase in individuals with the premutation who present with agoraphobia, social phobia, panic disorder, chronic pain in the females. Also other symptoms in males, psychiatric symptoms, mood disorder, major depressive disorder. We'll talk about these things in a moment regarding connective tissue, but their study shows that these problems show up even in a cohort of more than 20,000, I think, in that healthcare provider network, even when they don't know that they have the premutation. And some work from Emily Allen has shown in 350 premutation women is that some of the symptoms can cluster together. For instance, the clustering prevalence is related to the color here, red being a high prevalence, orange less so, yellow less so, and green much lower prevalence. So sleep problems can really up the prevalence of all these other symptoms, but mental health problems, particularly anxiety, ups the ante for this. If you have FXPOI, there's a higher number with complex problems. I'll show you this in another format in a moment, but also mental health problems. But there's a group that has minimal health problems too. And then FactsTasks symptoms are here, but most of these individuals did not have FactsTasks. And this just shows a graphical representation, the P less than 0.002 shown in red and marginally significant P less than 0.05 shown in black for the odds ratio. So if you have anxiety, it ups the odds ratio for all of these other problems. And depression ups the odds ratio for these. Hypertension or age at interview, the older you are, of course, the more of these kinds of problems you have. Smoking and BMI and age were the main things that up the rate and odds ratio of these problems. But anxiety is maybe correlated with the most of these problems. So it's really important to treat well the FXAND symptoms. And this is women with depression or anxiety. This is depression here in orange and no depression here in blue. And here with anxiety, self-reported increased number of comorbid conditions. So as you can see here, if you have depression, the low numbers, 0 problems or 1 problem, those that have no depression have fewer problems, and those that do have depression have more problems, more comorbid symptoms, just like the other sheet I showed you, same with anxiety. So here's a very interesting study from Marcia Malik from Minnesota. This talks about the healthcare problems in those with different sizes of the premutation. So one group is non-mosaic premutation carriers where they just have one allele size. Another group is premutation mosaic where they might have 2 different ones like 70 and 100 repeats. So 2 different, it's a little unstable. And then here is full mutation premutation mosaic where they mainly have a premutation, but a small number of cells may have a full mutation. So they looked in the first 2 groups, there were pretty big numbers. The ones with a little bit of full were less frequent, only 14 here. But what I want to show you is the non-mosaic versus the mosaic. They have far more problems than those that are mosaic pre and full. In other words, having a little bit of full makes you less anxious. This is felt anxious during the last week, had hot flashes during menopause. All of these things are less common in those that have a little bit of the full mutation. I expect my health to get worse, far fewer again compared to the mosaic premutation with the mosaic pre and full. after having a problem, I don't get over it very easily. Again, that's less common in those with a little bit of full. And so these are a variety of different emotional issues, lifetime diagnosis of anxiety, depression, or other emotional disorder. Only 7% in those that have a little bit of full mutation, but in the 40 percentile or 40% for those with premutation or a little bit of mosaic pre. So what's interesting, it kind of is counterintuitive that those with a little bit of full would have fewer problems. So I want to give you a case history. I love this case because she has an amazing tattoo that has the National Fragile X Foundation symbol on it, and she has defined normal. So this is a 64-year-old woman who presented with FactsTasks. She had a rapid course related to psychiatric and medical problems. And here's her story. She has 85 CGG repeats on the mutated X. She was well until November at age 63 when her mother died from FactsTasks. Now, she was the caretaker of her mother, and she got very depressed when her mother died. She was subsequently hospitalized because she developed type 1 diabetes, newly diagnosed, which is unusual. Then she had a panic attack in January, so fluoxetine was started and then switched to sertraline. She developed neuropathy problems with numbness and tingling. She developed balance problems. She began falling. She broke her hip, but did not require surgery, but her intention tremor began bilaterally. She began to drop things, her ataxia worsened, and now she's using a walker. And by June, and then she was seen for our genotype phenotype study in July of 2019. So she had a fairly rapid course over the 6-7 month period after her mother died. Now, it is stressful for you caretakers who are taking care of someone with FXTAS. So the stress probably developed long before that. But it's interesting, she didn't have the MCP sign. As you can see, her middle cerebellar peduncles are clear. She doesn't have that much atrophy, but she does have the splenium sign, and she does have a few spots of white matter hyperintensity in her cerebrum. So the premutation involvement across the lifespan, we do have changes that can occur in young children with the premutation, and we're able to demonstrate mitochondrial dysfunction. But in childhood, learning problems, ADHD, anxiety, social anxiety is pretty common, and occasionally we have someone with ASD. Young adulthood, the FXPOI can develop hypothyroidism. Many of these FXAND symptoms, sometimes they have additional genetic factors. We're very interested in the ApoE4 allele and how that could accelerate the onset of FXTAS. We're looking at environmental problems or exposures. The psychiatric and neurological problems, of course, can occur in adulthood. There can be additional medical problems that occur, or they can fall and break their hip and have to undergo surgery. But something often precipitates both tremor and ataxia and FXTAS symptoms and evidence of neurodegeneration on MRI. So what we try to do is keep individuals healthy, out of surgery, without exposures, definitely giving them antioxidants, and we can treat tremor and sometimes balance problems. Genetic factors could be protective or deleterious. And we mentioned about environmental toxins. We give everybody a sleep study because we want to get them on sleep apnea, CPAP machine if they're hypoxic at night, treat the psychiatric problems, avoid surgery, and really make lifestyle changes in terms of alcohol and drugs of abuse, and definitely stop smoking. Most symptoms of the premutation carriers are secondary to changes in the brain related to low-level RNA toxicity or mitochondrial dysfunction. I think even the psychiatric problems can be related to mitochondrial dysfunction. But that's not FXTAS. FXTAS is really a quantum leap in neurological problems where you see evidence of neurodegeneration in the brain, and that's related to white matter disease and more brain atrophy. And then if you're combined with Alzheimer's or Parkinson's disease or Lewy body dementia or multiple sclerosis, I think you can progress even faster with additional diseases. It's important to know that the premutation can cause enhanced neuronal cell death by 21 days. So it's like these neurons are a little bit more vulnerable, probably because of the mitochondrial dysfunction. And so they're at more risk, I think, for oxidative stress. We have also done some studies about connective tissue problems in carriers with FXTAS. Now, you all know that individuals with Fragile X syndrome can have loose connective tissue, sometimes joint dislocation, hyperextensible finger joints, flat feet. And we, many years ago, did skin on the skin. That's why individuals with Fragile X syndrome have soft and smooth skin. But the MMP9 matrix metalloproteinase 9, which is very important, not only for neuronal functioning, but also for the extracellular matrix, this elevation may lead to some of the changes of connective tissue problems. So they have prominent long ears, you know, all the features of Fragile X syndrome that we and many others have reported before. And but many carriers can have similar problems. I actually see many more carriers with back problems and disc protrusion problems and needing back surgery. And, you know, this could be related to connective tissue problems. I'm going to show you some of the Marshfield data in a moment. But those with the highest premutation levels would have the lowest level of FMRP in the premutation individuals and would be more likely to have more connective tissue problems. So we've also found, this is Koi Tasankipjanich, who is one of our international trainees who worked with us. And she pulled together those that were diagnosed with hypermobile Ehlers-Danlos syndrome. And usually the EDS diagnosis came before the premutation diagnosis. So here's an individual with 123 CGG repeats. She had migraines and a diagnosis of generalized anxiety disorder, chronic pain in her muscles and joints, diagnosed with fibromyalgia, irritable bowel, oversensitive to sensory stimuli, autonomic dysfunction, intermittent hypertension, and tachycardia. She was diagnosed with hyperextensible Ehlers-Danlos syndrome. And then when they finally did premutation testing, she was found to have 123 CGG repeats. So what I didn't realize is a lot of individuals with hyperextensible Ehlers-Danlos syndrome have many of the chronic problems that individuals with the premutation can have. Here's another one with just 104 repeats, but many FXAND symptoms, hyperextensible finger joints, hip dislocated easily, chronic pain in the joints, diagnosed with fibromyalgia, orthostatic hypertension, vertigo, and irritable bowel syndrome. So we do see these patients, and we're thinking that if they have similar FXAND or FXTAS symptoms, they should be tested for the premutation if they're diagnosed with Ehlers-Danlos or hyperextensible Ehlers-Danlos. Now, there can be SCAD or spontaneous coronary artery dissection. And what this is, it's part of a connective tissue problem, and we have reported it in 2020, where we saw 2 cases, and one was already in the literature, where there's a dissection in the coronary artery, and it can present like chest pain, like an MI or a myocardial infarction, and there's dissection here. And they won't be able to diagnose it until they do some imaging studies. intense physical exercise, emotional stress, fibromuscular dysplasia, high blood pressure, hormonal replacement therapy, and pregnancy and even giving birth can predispose to SCAD. This can also occur in other patients with Ehlers-Danlos syndrome or Marfan syndrome. So it's definitely related to connective tissue problems. And there's one other report in the literature before ours. And our student, Forrest McKenzie, is now a second-year medical student at UC Davis. So here's a 56-year-old woman with just 88 repeats, no known cardiac risk factors or connective tissue problems, enhanced evidence of fibromuscular dysplasia in bilateral internal carotid arteries. And she had FXAND symptoms with anxiety, depression. She had been experiencing very significant emotional stress for years due to the behavioral problems of her son with Fragile X syndrome, who had very severe PTSD after an episode where he got tasered by the police. But she had sudden crushing chest pain at age 56, and an EKG suggested an MI, but the angiogram demonstrated the SCAD changes in this circumflex coronary artery. So this can occur, and think about it if you see crushing chest pain. And this just validates some of the connective tissue problems that we see in premutation carriers, rotator cuff problems, fractures, intervertebral disc degeneration, displacement occurs far more frequently in premutation carriers compared to those without the premutation in this blinded study. And in the males, not only can there be urinary incontinence, but other disorders of cervical region and arthropathies. So these are common problems. Now, just a little bit about FXPOI, the Fragile X associated primary ovarian insufficiency. This is data from Marcia Malik, but others at Emory and elsewhere have reported this, Stephanie Sherman's group also, that there seems to be a high risk area between 75 to about 110 repeats where early ovarian failure occurs much more commonly, but when the CGG repeat increases, it's less of a problem. Again, there's fewer here, but if you get a little bit of lowering of FMRP, it may be protective, and we don't quite know how that can be protective from RNA toxicity, but maybe the FMRP deficit changes some of the binding parameters. But this is just another way of looking at it, that those were here with 100 to 104 repeats and 90 to 94 repeats, this group here has the highest risk for early ovarian failure. Now, many of you have heard about the AGG anchors. So about every 8 to 10 CGG repeats, there can be an AGG anchor. And this is important to add stability, maybe stability in replication, but the anchors lower the risk that the transmission of a full mutation from a premutation woman to her offspring is lowered. And to give you some examples of that, these are individuals either with 0 anchors, 1 anchor, or 2 anchors. And what you see here, around 70 repeats, is if they have 2 anchors, the risk of going to a full mutation in her offspring is much, much lower. We're talking about less than 10% risk than if she has 1 anchor, and the risk is about 39%. Or if she has no anchors, but 70 repeats, the risk increases to about 80%. So once you get over 90 or 100 CGG repeats, doesn't make any difference how many anchors you have. It basically will go to a full mutation every time that mutated allele is passed on. But for those individuals, that have a lower number of repeats, they really want to know through their genetic counselor what their risk is. And so having their anchors done, which they can get done at some laboratories. I think Assuragen does do that, and some of the other clinical laboratories do that. And of course, many research laboratories do that also. Here's just another way to look at it, percentage that go from a premutation to a full mutation in one generation. It's much, much higher, as you can see here, much earlier on with no AGG anchors. And then with one anchor, it reduces. And then with two anchors in the light yellow here, it's far lower. So that really adds stability, and that's important to think about. So I want to talk about treatment for a little bit. You know, this is a general paper that we published in 2018 talking about thinking about exercise and also the use of SSRIs like Prozac or Zoloft, fluoxetine, sertraline, citalopram, escitalopram. These stimulate neurogenesis, as does exercise. So if you want to build up your brain and have more neurons, you got to exercise, and you got to, you know, the SSRIs can be helpful also in aging. You want to reduce oxidative stress. You don't want to be vitamin deficient. Many people are vitamin D deficient or B12 or folate deficient. You also want to protect your mitochondria with antioxidants. You know, you want to alleviate factors that lead to CNS deterioration like high blood pressure, obesity. You remember that really brought on many more complex of symptoms in women with the premutation. You want to treat the anxiety, depression. You don't want to be hypothyroid for any period of time, because that can really cause disturbances in your cognition. You also want to treat sleep apnea, because being hypoxic at night is not good for you. You want to treat immune dysfunction. You know, there are some immune boosters. I drink echinacea tea. It's supposed to boost immune system. Maybe probiotics do too. You want to avoid toxins if at all possible. So you got to change your lifestyle. No smoking, dramatically reduce drinking, don't take opioids, avoid pesticides. And you want to give yourself cognitive stimulation. You know, I'm still working because I love the cognitive stimulation and I love the families. But there's other things you can do. There's cognitive training, meditation, biofeedback for stress reduction. I think that all can be helpful. There's symptomatic treatment for tremor. Primidone is the one most commonly used, but a beta blocker is good. Sometimes an anticonvulsant like Keppra, or even deep brain stimulation has a good effect on tremor, but sometimes deep brain stimulation can worsen ataxia. But if the tremor looks like a resting tremor or pill rolling tremor, or there are other symptoms of Parkinsonism, Sinemet, which is a dopamine preparation, can be helpful. Ataxia is difficult to treat. Sometimes amantadine or riluzole can be helpful, but not very commonly. You can easily treat pain. CBD can be helpful, gabapentin, pregabalin, duloxetine. This is Cymbalta. This is what's advertised on TV for fibromyalgia, because we like you to avoid opioids. You can treat depression and anxiety, as I mentioned, and CPAP for sleep apnea. Yes. Treatment studies in FactsTasks. We did do a controlled trial of memantine. It was not obviously helpful for tremor or ataxia or executive function, but actually there was a subgroup that also underwent event-related potentials. And in this blinded study, we found that their processing of auditory information and memory, recall memory, was improved on the event-related potentials. That's an EEG measure. Allopregnanolone, this is the hormone that's very high in pregnancy. And then when you deliver your baby, your allopregnanolone levels normally drop. Bregnanolone, which is the new postpartum treatment, is really just allopregnanolone, but it can only be given IV now. And we did a study of IV once a week for 3 months, and it did eliminate the neuropathy, and it did help several neurocognitive measures, but it was very expensive to do because you need an infusion center. And there's a company called PureTech that's making an oral allopregnanolone, which I think could be very helpful for FactsTasks. So we're excited to get, hopefully we get funded for that. We're doing an open label study of sulforaphane, which is a dietary supplement that turns on the NRF2 antioxidant system in cells, particularly neurons. Now, the NRF2 antioxidant system is an internal system. It's an enzyme that turns on many of the antioxidant normal systems in the cell. And it's been shown to be helpful in autism in a controlled trial. It's been tried for several neurodegenerative disorders, and we're doing an open label study of sulforaphane in 15 patients with FactsTasks to see if it can improve the biomarkers of mitochondrial function and oxidative stress. We're using a preparation called Avmacol, and you can take from 1 to 6 tablets per day, but we do a slow increase by 1 tablet each week, and you give it just at breakfast. You don't go over 6 tablets a day. And we're going to see if that makes a difference in the blood biochemistries or any of the symptom differences. Would metformin help in carriers? I do have a lot of carriers that are obese or have a type 2 diabetes that are on metformin. You know, metformin can be a targeted treatment for Fragile X syndrome, and we'll come out with the control trial data in the spring of next year. Metformin is great because it protects you against cancer, lowers your blood sugar, protects against vascular dementia because it has lowered blood sugar that is exposed to your brain and lowered blood pressure. And it also is anti-inflammatory, so it lowers inflammation. So it does help with aging. I like metformin. I'm on it because I don't want those aging problems, particularly the protection against cancer. So we have to do some future studies to see if metformin would be helpful for carriers. We don't know that yet, but maybe carriers who have lowered FMRP, it definitely would be helpful for. We are really excited about starting an ANAVEX study. So ANAVEX 2-73 is a medication that's a sigma-1 agonist. So it works at the sigma-1 receptor, which is between the endoplasmic reticulum and the mitochondria, and it reduces mitochondrial dysfunction, it reduces protein misfolding, it modulates the excessive calcium seen in those with the premutation, it reduces oxidative stress, it reduces inflammation, and it enables neuroprotection. So that sounds great. I participated in the ANAVEX study in Rett syndrome, and it did show efficacy in Rett syndrome. It's been studied in Alzheimer's disease, where it is clinically validated to stabilize or enhance cognition. It's been used in mouse models for depression, anxiety, epilepsy, Fragile X syndrome, and Rett syndrome. Actually, the Fragile X paper was just published last month. It's also been used in Parkinson's disease and has a positive effect for Parkinson's disease dementia. So I think it would be perfect for all these problems that occur in FactsTasks, and I think it probably would be good for those with Fragile X syndrome too, because it showed benefit in the mouse. But we've been trying to get a study going for 3 years, so hopefully next year we can get it going, and keep our fingers crossed. This just shows the Reyes et al. Paper where they looked at 3 behaviors in the Fragile X knockout mouse, and ANAVEX 2-73 improved several of the behavior features. For instance, it lowered the hyperactivity, it improved fear conditioning, it improved marble bearing, and it upregulated brain BDNF levels. compared to placebo. So I think there's a lot of benefit that could come from this. Curcumin and piperine have preclinical benefits for the premutation, and we haven't studied it yet. We want to do many more studies in Fragile X premutation carriers, and I know that David Hessel and Robbie Miller have worked with the National Fragile X Foundation, and the Fragile X Association of Australia has helped with creating the Fragile X Premutation International Registry. And you can join, you know, you can put your information in there. They ask you a lot of questions, and the information is kept confidential. And if a researcher wants to study, say, you know, 30 premutation carriers in Australia or elsewhere, or those with FXPOI or FactsTasks, you know, the message can go out to you about whether you want to join a study, you know, and a researcher would like to get in touch with you. So if you're interested in promoting research, join the International Fragile X Registry. I want to thank all of my collaborators, particularly Danuta Loesch at La Trobe University in Melbourne, Australia. You know, we had the trip scheduled to go to New Zealand for the premutation conference. And when they canceled the conference, our grandchildren said, well, we still want to go to New Zealand and Australia in March. So I worry that New Zealand won't open up. Hopefully Australia will open up. So I hope to be down under. Here's a great team. This is the clinical trials team and other people who have been involved in our research in premutation carriers and FACTS. And I'm just so lucky to have the best team in the world. And thank you so very much. I'm going to end now. And
Randi, we might come to a close. And so and I'll hand over to you, Ted, to do a final close, but from the New Zealand family, certainly thank you very much. As always, you're just a minefield of information and knowledge, and we appreciate that.
Thanks so much, Randi, for your talk. It was really great. And it was great to see you again. I want to say that the talk is recorded, and it should be posted on our website in a couple of weeks. And there will be some good references to FXTAS and premutation disorders. So, you know, you might check our website out in a couple of weeks. And in terms of registering for the International Premutation Registry, we'd like to encourage everyone to join up with that. Australia's been doing pretty well. We have close to 70 or over 70 now, which proportionately to our population is higher than in the US actually, which has, I did the math once on it. So I encourage you with that. So with that, thanks very much. And we look forward to seeing you here in Australia in the near future.